Welcome back to another episode of Christian Natural Health. Today, I'm very pleased to have Dr. MALAIKA Woods with us. Dr. Woods is dually board certified with the American Board of Obesity Medicine and the American Board of Obstetrics and Gynecology. She is the founder of Dr. Woods Wellness and the #1 best-selling author of Physician Unleashed, the Physician Freedom Formula. In addition to running her own independent practice, Dr. Woods also coaches other physicians and practitioners on starting and growing their own independent practices. When not working in the office, Dr. Woods enjoys singing, especially gospel music. She has been a choir director throughout the years and a wedding singer for many of her family and friends. Spending time with her wonderfully supportive husband, daughter, son, and close friends are her most treasured moments. Her secret ambition is to one day write a fictional book that gets turned into a blockbuster movie, and we should talk about that. Welcome, Dr. Woods. Thanks for joining us.
Thank you so much for having me, Dr. Lord.
Yeah, absolutely. So let's start by talking about weight gain in menopause. So why is that such a common thing that people seem to struggle with?
Absolutely. So, first, let's just define menopause. Menopause is technically 1 year without having a period.
Uh,
Now, for women who no longer have their uteruses from hysterectomy, et cetera, they can't judge it by that.
right.
So, there are some symptoms that go along with that. There's hot flashes, night sweats, vaginal dryness, those types of things. And one of those common symptoms is actually this belly fat around the middle. And literally, Dr. Lauren, I'll have women, whether it's in person or even virtually, just kind of grab around the middle and go, I don't know where this came
Yeah,
from. It
sure.
wasn't there, 18 months ago or something like
Right.
that.
Yeah, yeah.
What's happening during menopause is that your hormones are declining. So your ovaries produce the bulk of your main hormones that you would think of, like estrogen, progesterone, testosterone. And all of those levels are declining. What is typically happening, and I kind of look at it this way, so you've got estrogen kind of higher always, progesterone is lower, but as they are both declining, often progesterone is declining faster. So you, in essence, get a gap or what we call estrogen dominance. And estrogen is a fat storing hormone. So that's one of the main drivers behind seeing that extra weight during the menopausal years. And then just, of course, as women are aging, the metabolism slows down a little bit, maybe the thyroid, et cetera. So there's often a combination of things, but definitely those hormonal shifts are one of the really important driving factors of that.
And how do the adrenals play into this?
Great question. So, your adrenal glands produce cortisol, which is your stress hormone. That's one of the main things that the adrenal glands do.
Yeah.
And as far as stress is concerned, I ask this question to all of my patients, Dr. Lauren, like, how would you rate your stress? Well, and they'll give me a number like on a scale of 1 to 10.
Yeah.
And then I point out this idea that there's different types of stress. So there is the perceived stress or the emotional stress. When you go, it's 5, it's 7. And some people are just naturally cool, calm, and collective, and that's just their personality. So they're never,
Right.
quote unquote, stressed
Right.
according to them.
Sure.
However, there is dietary stress. So
Right.
sometimes you're eating foods that are inflammatory to the body and causing stress. And
Sure.
then there's pain and inflammation that come from other sources that are
Mhm.
also a cause of stress. So I
Mhm.
think that's important to note about stress.
Mhm.
Also, this idea that whether the stressful event was yesterday or even 5 years ago, sometimes it can have a lingering impact on the body and the body's, mechanisms. And so cortisol directly can inhibit the conversion of your thyroid hormone from inactive to active. And then, if anybody knows anything about the thyroid, it's one of the most important hormones as it relates to energy and metabolism. So, stress plays a role in that way. And then, cortisol is another fat storing hormone. So, that's another one that we don't want to be. I'm going to use the term out of balance
Right.
loosely because there's
Right.
really kind of probably not such a thing as hormone balance. It's
Yeah.
really more about optimization, but kind of the layman's term is balance. And so you don't want your cortisol, quote unquote, out of balance, nor your other hormones.
Yeah. And one of the things that I thought was that I found to be really interesting as far as all of this is concerned is progesterone being the precursor to cortisol. So, like when you're going into menopause, if your adrenals are already lower, then progesterone plummets faster. Is that true?
Absolutely. So we
Yeah.
call it the progesterone steal. You may have heard of it, or the pregnenolone steal. So when you look through those cascade of hormones, you start, cholesterol is a parent body, first of all of your sex hormones and even cortisol. So that's why I always tell people, all fat is not bad. You need some cholesterol in your system.
Right.
Obviously, we don't want it too
Absolutely.
high. But from cholesterol going a few steps down, you get DHEA, which turns over to testosterone. DHEA going down a few more steps, you get progesterone, you get cortisol. So
Mhm.
there's definitely a link between all of those hormones. And if you're pulling away, basically because you're stressed, you're kind of pulling away from your
Right.
body's ability to make some of those hormones upstream from cortisol.
Absolutely. And because of that, I don't know what you found, but certainly in my practice, I've seen that a lot of women, when they're going into menopause, if their adrenals are low or if there's toxicity, they seem to have a harder time of it. Do you find the same?
Absolutely. And so on the topic of toxicity, one of the things that I talk a lot about is just sort of the impact of inflammation. And so obviously if you're toxic, you're inflamed.
Yeah.
And if you're inflamed, your body's not going to burn fat well, because if you think about it in another way, whether it's toxins specifically or if it's inflammation, the byproduct of that,
Right.
your body's always trying to protect you. Like,
Mhm.
one thing that I tell people all the time is that your body is divinely designed, has a great capacity to heal. And in its effort to protect you, those inflammatory markers, those toxins are often stored in the fat cells, kind of to
Yeah.
keep away from, just the normal mechanisms of the body. And
Sure.
as a result, those toxic fat cells are not going to want to shrink, which is what we really
Want to
want
give it
them to
up.
do.
Yeah.
If we're trying to- yeah.
Sure. Yeah, absolutely. That makes sense. So you mentioned that estrogen tends towards storing fat. Estrogen, I've always kind of thought of also as helping with water retention. Are those two things happening simultaneously, or does one happen and then the other happen, or how do those things relate to each other?
They definitely can be happening simultaneously. I guess for me, when I see that transition, I kind of look more at that
Yeah.
um, influence as far as being fat storing. And what's interesting too, and this is what I love about how these hormones kind of balance each other,
Yeah.
kind of your take on estrogen kind of helping with fluid, because progesterone, though it's very beneficial,
Yeah.
it can cause, especially if you're in the realm of like hormone replacement, or if you're taking progesterone, which is a lot of what I do in my practice, what
Mhm.
you'll find is that sometimes progesterone can cause a little fluid retention. Initially, it usually will kind of balance itself out, but
Yeah.
it's just another kind of great just to look at how those hormones balance each other. One
Sure.
might put a little fluid, one may lean toward removing fluid.
Right. And so one extra piece to tease apart here. So it's the estrogen to progesterone ratio that makes that's most important. But at the same time, there's also the testosterone. How does testosterone play into weight?
Oh, that is a great question. And so let me just start off first of all by saying I think a lot of women, especially, have the wrong idea about estrogen and I'm sorry, about testosterone, in my opinion. So I think, first of all, people sort of mistakenly think that testosterone is only important for men, which is not
Right.
true. And
Sure.
then a lot of people mistakenly think that testosterone is only about sexual function, and that's not true either. So
Right.
certainly testosterone can help with libido and can enhance orgasm, that kind of thing. But then the non sexual benefits of testosterone are related to increases in energy, mental clarity, building muscle mass over time. And that's the key as it relates to your metabolism. Building muscle mass over time so that you can burn fat more efficiently. So,
Right.
obviously, it's not like a weight loss fix, but the way I describe it, it's sort of like turning a dial in your favor as
Right.
far as your metabolism is concerned.
Right, that makes sense. So one thing that's really interesting about synthetic hormones versus bioidentical can be that if you end up adding in, like sometimes some women, for example, will gain weight with birth control, certain birth controls. Of course, not that doesn't happen with everybody. With bioidentical hormones, do you always notice that if the estrogen is high and you give progesterone, that the weight falls off just with that? Or do you have to make sure that you've got all of them in the mix?
That is a great question. And so the way that I determine, which hormones are needed, it really depends on the individual woman, but I'll give you kind of a rule of thumb.
Mhm.
Women who are earlier in the stages, let's say they're kind of perimenopausal, and that just basically means you're starting to get symptoms, but you haven't hit the clinical definition of menopause. So
Right,
they're already, again, the hot flashes, the night sweats, the weight gain, et cetera.
right.
Usually the last thing they need in a lot of cases is estrogen.
Mhm.
So I often will start with progesterone and testosterone, because the thing with estrogen, even when your periods are spacing out, and even when you've stopped having a period for a number of months or even a year, you're
Mhm.
still potentially having some fluctuations in those hormone levels. And so one of the things that you want to be most cautious about is overshooting on the estrogen.
I
So
agree.
you always want to kind of start with that last. So I
Hmm.
love progesterone because, and this is my secret weapon hormone, by the way, Dr. Lord, and you probably
Yeah.
know about this too, but it helps with sleep and it helps with mood. And
Mhm.
so those are two amazing things about progesterone. It works at the GABA receptors, the neurotransmitters on the brain, just to have a calming effect. So
Sure.
all of those women, you know, who are dealing with anxiety and irritability and these types of things as they're getting into their 40s and 50s and beyond, progesterone can do wonders there.
Mhm.
The other thing about progesterone and kind of speaking to the complement of these hormones, what I find also, let's say if a woman is having hot flashes, but she's just in her mid 40s and her labs show that her estrogen levels still look present at least. What
Mhm.
I find is that giving progesterone, because it has a similar enough chemical structure, it can
Yeah,
actually help to alleviate some of those classically known as estrogen deficient symptoms.
sure.
And then when we get to testosterone,
Mhm.
again, I love to start with that for most women also.
Mhm.
And a little bit of testosterone does convert to estrogen, kind of speaking of the
Yep,
cascade and how all those hormones are connected. And
right.
so again, we can help the estrogen deficient symptoms without giving estrogen right off the bat. And I
Sure.
think that's the best way to avoid overshooting or giving excess estrogen.
Yeah, and one of my favorite ways to get there is DHEA as well, same concept. So like that one's going to feed that whole pathway and support the adrenals too. Yeah, yeah, very cool. So, what would you say to a woman who wants to balance her hormones, but maybe doesn't want to jump to bioidenticals quite yet? Do you have like some go-tos before that?
Yeah, absolutely.
Yeah.
So I think, first of all, we got to talk about basic lifestyle things first and not overlook that, right?
Right.
So
Yeah, of
there are
course.
some things that are what I call menopause pretenders, because sometimes you're having symptoms and you're thinking you're in menopause, but it may be you're struggling with a menopause pretender. And one of those is alcohol. You know, you're having, you know, a lot of women want to have a glass of wine at night to relax and things
Sure.
like that. But
Yeah.
what but what's happening and what they need to understand is that that is often a menopause pretender, meaning that when you get that blood sugar swing in the middle of the night,
Mhm.
that's going to bring about sweats for a
Mhm.
lot of women.
Sure.
And I know you know this, Dr. Lauren, so I'm just kind of speaking to your
Sure,
audience.
yeah, of course.
You know, your blood sugar is going to spike initially, right, from that glass of wine. And then in the middle of the night, your blood sugar's tanking. You got to kick in cortisol. Your body's trying to get the blood sugar up, and you're starting to sweat. And
Mhm.
so sometimes you got to, again, deal with the menopause pretender of alcohol, deal
Yeah.
with another menopause pretender of sugar. Okay. That
Yes.
is another big one. Same phenomenon that happens at night when you get
Yeah.
in too much sugar, even outside of alcohol.
Mhm.
Definitely getting your rest, which is super important. And a lot of people overlook the importance of sleep. Also, getting in regular physical activity. All of these things are going to help in that menopausal transition if
Right.
you're not ready to go into bioidentical hormones. And then if we get into supplements, things such as DHEA, which you've already mentioned.
Mhm.
There are other things like chaste tree, magnesium. So there's several different herbs that can help with that too.
Yeah, gotcha. So, what would you say to women who are concerned about the potential risks associated with like synthetic hormones and also versus bioidentical hormones? Can you give us kind of the arguments on both sides of that fence?
Yeah, absolutely. And it's you know, it's a story that has been developing and very controversial really over the last 20 plus years, kind of like my entire time in practice. So I remember Dr. Lauren, back when I was a resident, that's when the big Women's Health Initiative study came out back in 2002. What that study was, it was a randomized clinical trial. Women average age 62. They were giving half of them Premarin, which is synthetic estrogen. Premarin, as in pregnant mare's urine. That's where they got it from. And then the other arm of the group, they got Prim Pro, which was the synthetic estrogen, along with the synthetic progestin, which is what we should technically call it, other than progesterone,
Right.
that medroxyprogesterone acetate. So basically, they stopped the study early because of a concern for the risk of breast cancer, heart attack, and stroke. So
Mhm.
back in 2002, the big message was hormones cause cancer, hormones cause, you know, heart attacks, and basically everyone should be off of their hormones. And
Mhm.
so I kind of imagine during that time, you know, all the primary care docs were just ripping up all the prescriptions for
Right.
hormones. And
Yeah.
the only docs that were still prescribing hormones were the OB-GYNs, such
Uh-huh.
as myself.
Yeah.
Now, the backstory behind that too is that there had been decades of data. A lot of it was, observational, so it wasn't the highest standard that we consider the randomized clinical trial, but there was a lot of data showing the benefits of hormones. And we thought before the Women's Health Initiative, you
Mhm,
put a woman on hormones when they hit menopause and you keep them on it for the rest of their life. And then
mhm.
this study came out and, it was a
Right.
huge 20 some years later, and after kind of unpacking this data, several things have come out as a result. And I think a lot of people agree that that initial statement was really an overstatement of the results, and it didn't always apply to what was happening clinically. So I mentioned at the top that the average age of the woman in that study was 62. Now,
Mhm.
we don't usually start a woman on hormones at the age of 62. We're
Right.
starting in their mid 40s, maybe in their
Sure.
50s.
Right.
So one of the theories was that maybe the increased risk of heart attack and stroke was because a lot of these women maybe already had pre-existing disease,
Mhm.
pre-existing cardiovascular disease. So I
Right.
could go on and on about that, but 20 plus years later, what we saw in that data now is that the younger women really didn't have an increased risk of heart attack and stroke. And by younger, I mean really up through the age of 60. We also saw that even on the synthetic estrogen, there
Mhm.
was a 30% reduction in osteoporosis, a 30% reduction in colon cancer.
Mhm.
So those are some of the big things that came out of that. And I think other data that has come out since then, we see, say, like the nurses' health study, which is a big observational study. They show a 30 to 50% reduction in heart disease for women who've been on hormone replacement. What we
Mhm.
don't have a lot of, actually, Dr. Lauren, is big studies on bioidentical hormones. We don't necessarily have as
Sure.
big of a study as the Women's Health Initiative. But
Mhm.
just to give you another example of, let's just say, the difference between progesterone and the progestin.
Mhm.
I think one of the biggest links too in the Women's Health Initiative study, it was the progestin, the synthetic progestin, that really was the culprit
Mhm.
as far as that risk of heart attack, stroke, and breast cancer. So the
Right.
women in the synthetic estrogen arm did not show an increased risk of breast cancer. In fact, it was showing lower incidence, but it wasn't clinically significant. So it was actually less breast cancer. So
Yeah.
again, you could go on and on with that data. But
Feels, yeah.
let's take progesterone. So bioidentical progesterone, again, we talked about sleep, we talked about mood, but if you take synthetic medroxyprogesterone acetate, it
Mhm.
actually can be associated with weight gain. Think about the Depo-Provera shot as a
I
great
know.
example.
I was going to ask. Yeah. Mhm.
And the Depo-Provera shot also has, it had a black box warning, at least when I prescribed it years ago. If you had significant depression, you shouldn't take it. So
Mm.
those are just one difference between bioidentical versus synthetic. And a
Sure.
lot of the traditional OB-GYNs now are prescribing more commercially prepared bioidentical
I've
hormones. So you
noted.
can get that from your traditional gynecologist if you have that discussion, I think.
Right. Yeah, absolutely. And overall, I'm assuming your preference is bioidentical. Is that true? It is.
Absolutely.
Yes. Okay. And what's the main reason that you prefer that over the synthetic?
Yeah, so one of the main reasons why I prefer bioidentical is because I feel like, number one, like with the progesterone, there's really no question there. The other thing that's nice about the bioidentical is that we can really create preparations very unique to our patients. And
Sure.
that is the reason why we're able to get particularly compounded bioidentical.
Right.
And the reason why we're allowed to have compounded medications is because we can create a dose that's very unique.
Mhm.
Whereas if you get a commercially prepared, there's just, dose one, two, three, and
Right.
there's nothing in between or above. So those are some of the reasons why I really like the bioidentical.
Gotcha. So if you have a woman who is very frustrated about her weight and she's tried the hormones and maybe that hasn't had as much of a benefit as she'd like, what's your take on all of the various things? Like everybody's asking for Ozempic and all that stuff right now, all the other approaches commercially for weight loss. Tell us your thoughts.
Okay, so obesity medicine is another one of my certifications. So one of the things that I found very interesting
Mhm.
about this, and I remember back when I was kind of doing my coursework, they had a graph of all the different ways a person could lose weight. This is prior to Ozempic.
Mm,
Whether you had surgery, whether you took medication, whether you
yeah,
did diet or lifestyle, if you looked at the graph over time, everybody lost a significant amount of weight. And if you continue to follow them over time, they started to gain weight back.
right.
So, one of my big take home points then is In some ways, losing weight can be easy, but keeping the weight off is really the challenge. And so
Challenge.
that's what I really try to work with people on. Again, of course, addressing lifestyle factors first.
Yeah.
I do use, old style traditional things like phentermine, which is just a basic appetite suppressant. And Dr. Lauren, I also use GLP-1s, compounded as well, but I have a little bit of a different approach. I call it the functional medicine approach to it. So the first idea is that we're going to use it as a tool. It's not meant to be a
Right.
forever type medication for
Yeah.
someone who's trying to lose weight.
Mhm.
Secondly, we're going to do the dosing differently so that we hopefully eliminate any of the significant side effects and sort of the
Right.
horror stories that people hear about. Like, and I was slow to start using this with my patients because I had, suspicion about it. I had concern about it, I should say. So I
Yeah.
remember reading a story about some lady. She said she threw up every day for a year. I'm like, well, first of all, why were you on it for a
I
year?
know.
Day two,
Sure.
right? So
Maybe take that as a clue.
yeah, so these horror stories you hear about, like all this nausea, vomiting, we're able to microdose it using compounded
Yeah.
versus the standard preps, you start at a pretty high dose. The other thing too is that we really stress the importance of the lifestyle. Strength training is important. So one of the other things that people probably hear is that you lose a lot of muscle mass potentially if you use this medication.
Yeah.
And the reality is, any method that you use to lose weight, if you're losing it rather rapidly, you're going to risk losing a lot of muscle.
For
And
sure.
so you got to do your strength training and those types of things to counteract that. So
Mhm.
that's the way that we do it. We do it kind of cautiously as a tool
Yeah.
and then a team approach. So I have an integrative nutrition coach on my team. We see people regularly. So we want to give them guidance along the way, not
Right.
just like, here's your medicine and we'll see you in 3 months or whatever.
Fantastic. And so what's kind of the average length of time that you have somebody on a GLP-1, for example?
Yeah, I would. So, of course, it depends on how much weight they're trying to lose,
Or
but I
yeah.
would say probably 6 to 9 months is pretty common for someone who's like 20-ish, 20, 30 pounds. If they're more than 30 pounds, then they're going to be
A
leaning for
little
a
bit
little bit more than that.
longer. Gotcha. Yeah. Okay. And I'm assuming like, do you find that you have to monitor things like liver enzymes, pancreas enzymes, stuff like that, or not really microdosing?
Yeah, we do
Yeah.
certainly a set of baseline labs, which will check liver function. And then we follow that. I look at labs about every 6 months at least anyway on
Sure.
all of my patients. So we check it then too. But I've honestly had no major complications.
Good.
And
Yeah.
I haven't had anybody who had to stop the medication because of side effects. So
Okay.
people have done very well with it.
Gotcha. Awesome. And so, taking kind of a step back and looking at your overall philosophy, how do you integrate your holistic philosophy of medicine with your faith? How do you see those interacting with each other?
Yeah. So, let me just tell you a little bit of story that really impacted me.
Yeah.
So, back when I was in medical school, my husband actually lost his vision and lost his vision. We didn't know what was going on. He was
Right.
having numbness and tingling in his body.
Yeah.
We came to learn that he had multiple sclerosis. And
No.
so, by the time we got there, he was pretty blurry in both
Wow.
eyes. And so, we went to see a neuro-ophthalmologist at the
Mhm.
University of Kansas. I believe his name was Dr. Whitaker. The first thing he said when we sat down was, "Is it okay if I pray with you?" I was
Awesome.
like, I was a medical student, so there was a lot I didn't know right
Of
at the time. So we were just scared. We didn't understand what was happening
course.
at the time. And so that had such a huge impact on me to see a physician pray
Right.
with the patients. And
Yeah.
so that gave me courage to offer that. Now, I don't pray with every patient every time,
Yeah.
but there are certain situations like someone has had a loss or there's something difficult happening. I will say, hey, is it okay if we pray? So,
Yeah.
and I will honestly tell you too, Dr. Lauren, it was probably after I started my own group, my own practice that I
Mhm.
felt more comfortable to do that. But
Yeah.
I've been in my own practice now since 2012. So, I've been doing it for a while.
Right.
Thing I would say too is that, just kind of first of all, being in the field of obstetrics and gynecology, where you're sort of helping to usher in life, like that's just a beautiful thing to
Right.
witness. It kind of puts you in awe of this entire process and acknowledging, that there had to be a God behind it. You know what I mean?
Yeah.
These things are just not happening randomly.
Sure.
It's the way that I see it as well. And it was way back in the eighth grade biology class when I learned about reproduction that I thought, it'd be neat to deliver a baby.
Yeah,
And
yeah.
with that and ended up, being an obstetrician gynecologist. So
Uh-huh.
that's another thing. And then taking it beyond just traditional medicine and now doing functional medicine,
Mhm.
where I'm just reawakened to this idea of how many ways that your body is working for yourself, can heal itself. Like, my mind was blown when I, learned about functional medicine, and I was a little bit upset because I'm like, why
Why
didn't
didn't
you
they tell
tell
us this?
me about this stuff? You know what I mean?
Right.
Like
Yeah,
our
yeah.
bodies are so ready to just
Sure.
repair and regenerate and
Yes.
do all these amazing things. And I'm just like, this is not by happenstance.
Yeah. Oh, absolutely. And so segue onto that, how did you transition from a more traditional practice to functional medicine? How did you make, like, what made you decide to make that jump, I guess?
So I was in a busy OB-GYN group.
Yeah.
I was a year out from having my second kid. I was about 240 pounds. So
Mm,
I had gotten to my heaviest. I was stressed at work, and I knew I needed to do something different for myself. So
right.
I began by learning about obesity medicine, and I started helping patients lose weight. And
Uh,
so the first weight loss program I learned about Dr. Lauren it was 5 shakes a day.
yeah.
Did it myself. I lost 20 pounds, but I had the worst constipation of my life. So
Oh,
I'll
gosh.
do that again. I was the first 20 pounds down.
Yeah.
And then I'm going to kind of share my weight loss journey as I tell
Yeah.
you this transition. And in my group, they were telling me I need to see more people. I was like, I can't do this like this hamster wheel. I just started to feel
Sure.
like this is not why I got into this. I
Right.
want to be able to develop rapport and spend time with
Right.
my patients, and I wasn't able to do that anymore.
Right. Right.
So I decided to leave my group at that time. And initially, I was just going to do regular OB-GYN and a little bit of weight loss. That was kind of what I was going to do.
Mhm.
And then I learned about bioidentical hormones, really from patients coming in, telling me how
Yeah.
amazing it felt. And I
Yeah.
was like, well, let me check this out. And
Yeah.
so when I did my training, shout out to World Link Medical and Dr. Neil Rouzier, again, mind blown again. I'm like, I'm a fully board certified OB-GYN, and I don't think I know anything about hormones really. So
Wow. Yeah.
also, and I started offering that. And so
Mhm.
I developed sort of a cash-based practice alongside my traditional OB-GYN practice. And
Mhm.
then that started 2012. And then 2015, I decided to stop taking insurance because the other side of the practice was kind of growing.
Taken on. Yeah.
And as I was learning bioidentical, a good friend of mine who's a physician who lives in California, she mentioned functional medicine. Now, this was back in like
Mhm.
2013, 14. I was like,
Yeah.
what is that? I've never heard of it.
Oh,
And
wow.
so she told me about it. And then she and I, first we were like seminar sisters. Now we're just
Sure.
like sisters. But
Yeah.
we did all the coursework together. So I got certified with the Institute for Functional Medicine.
Right.
So the way that I look at it now is that functional medicine is the umbrella under which I do everything else. So that's really the umbrella and then also the foundation, if you will. And in
Yeah.
the process, personally, I lost another 20 pounds on phentermine that my doctor prescribed for me. And
Yeah.
then the 20 pounds I lost just with diet and exercise and kind of those regular things. So I
Sure.
lost 60 pounds over the course of 2 years from
Gotcha.
2011 to 2013. So that was kind of my personal transformation and then also my career transformation as well.
Right. Awesome. Very cool. So, what have I not asked you that you want to make sure you leave with our audience?
This is one of the things that I really want to stress with people because I know that sometimes it can be frustrating when when you're dealing with something going on with your health. Whether you don't have a diagnosis or maybe you have a diagnosis and now you don't know sort of what the path is going to be for you going forward. I
Mhm.
want to encourage your listeners just with the idea that your diagnosis is not your destiny.
Amen. Yes.
Um, and that goes back to your faith.
Mhm.
That goes back to the idea that just understanding that your body is divinely designed and has a great capacity to heal.
And
And even in the midst of, whatever it is you're walking through, because some things, you're not going to get rid of perhaps, but you can always give God glory in the midst of whatever your journey is with your health.
Mhm.
But I really want to encourage people to just be encouraged in the idea that that diagnosis is not their destiny. Because sometimes I think people think, well, my grandmother had diabetes, so I'm
Right.
probably going to get it. And they don't realize that that could be reversed. Like you can put yourself
Mhm.
on a totally different trajectory. So
Right.
that is really the message. The diagnosis is not your destiny.
Yes, absolutely. Where can people go to learn more about you?
Okay, so I actually have a free Facebook group called the Natural Hormone Fix. So
Mhm.
you can look that up and you'll see my smiling face there, and you can ask to join, and we go live and we talk about, hormones from the functional medicine perspective. And then
Mhm.
I also have a free report called The 3 Secrets to Hormone Balance Every Woman Should Know. And you can grab that online, drwoodswellness.com/guide, GUIDE.
Perfect. I will link to that in the show notes. And thank you so much, Dr. Woods. This has been really educational. I appreciate it.
Thank you so much for having me.